Welcome to Respiratory HQ. I'm Tonya Piehl. Today we're going to talk just a little bit about the difference between hypoxemia and hypoxia. Because in clinical practice, we use these terms sometimes interchangeably, which can lead to confusion when you're just starting out in respiratory therapy. So let's start out by making sure we really know the differences between the two. Start out with hypoxemia and just use medical terminology. Emia means in the blood, hypo means low, ox is oxygen, so low oxygen in the blood. So if you've watched the video about oxygen diffusion at the lung, you'll remember that when we breathe in, there's a certain pressure of oxygen in the alveoli, and that oxygen is driven across to the pulmonary capillary bed, where it's transported in two ways, bound to hemoglobin and dissolved in plasma. So this is what we're talking about when we're talking about hypoxemia, is that inadequate amount of oxygen in the blood. Typically, we assess it by the PaO₂, or arterial oxygen tension. And we have guidelines, if you will, and you're going to use these values throughout your entire career. So normal oxygenation will be a PaO₂ of 80 to 100 millimeters of mercury. Mild hypoxemia is a PaO₂ of 60 to 79. Moderate, a PaO₂ of 40 to 59, and severe is a PaO₂ of less than 40. Now, if you remember when we talked a little bit about the oxygen hemoglobin dissociation curve, we can use this PaO₂ to estimate the SATs. So when we're talking about inadequate quantities of oxygen in the blood, we usually use a blood gas, but you can also use a pulse ox, because oftentimes there is correlation between the two. All right, rule of thumb for hypoxemia: as we get older, our lungs are not as capable of handling diffusion across the AC membrane. As we age, diffusion gets a little worse over time. So for patients that are older than 60, the lower level of the acceptable PaO₂ decreases because of the aging process. So for every year over 60, the PaO₂ is going to decrease by 1 millimeter of mercury. So for example, if we have a patient that is 70 years old, that's 10 millimeter of mercury different for that age change. So their normal PaO₂ would be 70 to 100, and that accounts for the aging process. However, anytime that PaO₂ is less than 60, they do have some degree of hypoxemia. All right. And oftentimes we can use the PaO₂ to tell us if a patient has responsive hypoxemia or refractive hypoxemia. So refractive means that the type of hypoxemia they have doesn't respond to oxygen therapy. So there are two guidelines to use. So if a person's on an FiO₂ over 50 already and their PaO₂ is less than 60, they have refractive hypoxemia. That oxygen isn't working very well for them. Or another way we can use a rule to determine refractory hypoxemia is when there is a 20% increase in the FiO₂ and less than a 10 millimeter mercury change in the PaO₂. We call that refractory as well. So typically refractory hypoxemia results from a physiologic shunt. So basically what we're saying, if there is a shunt in the lung, a large area of atelectasis, a very large area of pneumonia, if they have ARDS, it's going to take more than oxygen to treat that hypoxemic state because it's refractive to the addition of oxygen. Responsive hypoxemia, however, is when there is a significant response to oxygen therapy. So when you increase the FiO₂ by 20% or more, there's going to be a 10 millimeter or more millimeters of mercury change in the PaO₂. Oftentimes, responsive hypoxemia results from VQ mismatching, just a little bit of atelectasis, maybe a mild pneumonia. So when you put oxygen on these people, you expect to see a pretty significant change in the PaO₂. All right, so hypoxemia, low oxygen in the blood. Hypoxia is inadequate quantities of oxygen at the tissue. So the tissue of the body doesn't have enough oxygen. And there are actually 4 types of hypoxia. We have hypoxemic hypoxia, anemic hypoxia, stagnant hypoxia. The more recent name, or the name you probably are going to hear for this, is circulatory hypoxia and histotoxic hypoxia. And so the reason I use stagnant hypoxia is you can remember the types of hypoxia by the acronym H.A.S.H, H-A-S-H. So hypoxemic, anemic, stagnant, histotoxic. Just remember, stagnant hypoxia is now called circulatory hypoxia. So let's just define those real quick. So hypoxemic hypoxia is when there is hypoxia to the tissues because there's a decreased amount of diffusion between across the AC membrane. So there may be oxygen in the alveoli, but for whatever reason, it is not crossing into the pulmonary capillary bed to be bound to hemoglobin or dissolved in plasma adequately. And so if you start out with a low amount of oxygen in the blood, eventually that could mean that there's a low amount of oxygen in the tissue. So hypoxemia, hypoxia. This type of hypoxia, because it is caused by hypoxemia, is fairly responsive to oxygen therapy as long as there's not a physiologic shunt in the lung. All right, anemic hypoxia is the decreased carrying capacity of blood for oxygen. That's a little wordy, isn't it? So remember when we talked about oxygen is transported in 2 ways, bound to hemoglobin and dissolved in plasma? We're talking about the bound to hemoglobin portion of that equation. So if the hemoglobin is low, that is anemia, right? So a person will have a low amount of hemoglobin. They won't be transporting as much oxygen to the tissues, resulting in hypoxia. Or carbon monoxide poisoning. So we talked about the saturation of the hemoglobin. So if something is attached to that hemoglobin, like carbon monoxide, there's not enough oxygen on that hemoglobin to be taken to the tissues. So anemia and carbon monoxide poisoning can cause anemic hypoxia. Now, hypoxemia, on the other hand, may or may not be present, meaning if you look at the PaO₂, it might be normal because this isn't that side of the equation, okay? So you can have a PaO₂ of 80, but still have a hemoglobin level that is low, or carbon monoxide being bound to that hemoglobin instead. Stagnant hypoxia, more appropriately circulatory hypoxia, the definition is a decreased cardiac output. So the left ventricle is not pumping enough blood into systemic circulation, resulting in an increased systemic transit time. That's really wordy too. All that means is because there's not much blood being pumped into systemic circulation, it's taking it a long time to get back to the right side of the heart. And basically, there's not enough oxygenated blood to take care of all the oxygen needs to the tissue. All right, so typically this is a result of shock. There are different forms of shock, but shock really means a profoundly low blood pressure. All right, so shock can cause circulatory hypoxia, cardiovascular instability. Maybe there's a cardiac dysrhythmia that's affecting cardiac output. And if that's the case, it will cause circulatory hypoxia. Or regional vasoconstriction. So a lot of times we give medication that to bring up blood pressure, it causes a lot of vasoconstriction in the extremities. And in the extremities, there's going to be a type of circulatory hypoxia because those vessels are so constricted, blood cannot get to that area of tissue to offload its oxygen. So if a person has circulatory hypoxia, it's going to be best treated by restoring circulation. So we need to bring blood pressure up. Maybe we need to treat that cardiac dysrhythmia. So whatever is keeping that oxygenated blood from circulating through the body, we got to give attention to that. And then the last type of hypoxia is histotoxic hypoxia. It's the inability of tissue to utilize the available oxygen. So with this, there is plenty of oxygen in the blood. So here's the bloodstream, and this is our CaO₂, and it's normal. There's normal hemoglobin, normal saturation, normal PaO₂. So this is absolutely normal. So there's plenty of oxygen in the blood. Here's the tissue of the body. Yet there is something like cyanide poisoning that keeps that oxygen from the capillary bed or from the arterial system in the body to diffusing into the tissue. So it creates like an invisible barrier here, and that oxygen that's in the bloodstream can't diffuse past that poisoning to enter the tissues, and so the tissues are going to lack that oxygen, resulting in hypoxia. So definitely a difference between the two. So as we start using these terminologies when we talk about oxygen therapy or talking about our patients in clinical practice, just remember hypoxemia is a low amount of oxygen in the blood. Hypoxia is an inadequate amount of oxygen to the tissues. Hope you found this beneficial. Have a great day.